Okay. Hello. Guten Tag. My name is Tatiana, and I want to present you a presentation for responders, a story of success. Russia is in the second place in terms of the number of IVF cycles performed according to the data of ESHRE in 2017. And the Samara Regional State Center of Reproductive Medicine in the largest in the Volga region. We provide about 1,500 fresh cycles per year and about 1,000 frozen cycles per year. Over 17,000 IVF and ICSI cycles completed since 2008, and we already have over 5,000 children. In the modern world, women used to delay childbirth in order to make a career or engage in self-development. And half of patients appealing to IVF are at the advanced maternal age, over 35 years old. You can see in our diagram, this is the patients of our center. And but pregnancy rates in fresh cycles with oocytes, according to the maternal age, are decreasing with age. According to the results of our center, the pregnancy rate in the group of patients less than 35 years old is 47.2%, and in the group of patients over 40 is 11.3%. And the live birth rates decreased from 28% to 5.3%. Another problem is the maternal age. It affects on aneuploidy. Here you can see that the percent of embryos with aneuploidy rises from the age of 35 and to 44, where it makes up to 90%. And at the same time, the percent of miscarriages rises and the live birth rate decreases here and here. So how many eggs do we need to have a good pregnancy? That is the question. It is estimated that mean number of matured oocytes required to obtain at least one euploid embryo for a young woman is 4, and for a woman over 40 is 10, and even 20 over 42 years old. But the ovarian reserve declines with an age, and we face the problem of poor responders to the ovarian stimulation. There are 4 groups of low prognosis patients in assisted reproductive technology according to the Poseidon certification based on oocyte quantity and quality. In the first group, there are patients, young patients less than 35 years old with adequate ovarian reserve parameters, enteral follicle count over 5, and anti-Mullerian hormone over 1.2 nanogram per milliliter, and with unexpected poor or suboptimal ovarian reserve and response. In the second group, there are older patients over 35 with adequate ovarian reserve parameters and with unexpected poor and suboptimal ovarian response. In the third group, there are young patients less than 35 years with poor ovarian reserve parameters, enteral follicle count less than 5, and AMH less than 1.2. And the fourth group that consists of older patients more than 35 years old with poor ovarian reserve parameters and poor response. That is the hardest group of patients for treatment. And what is the etiology of poor ovarian response? However, some of the recognized etiologies include age-related depletion of ovarian follicles, advanced endometriosis, chromosomal genetic alterations, prior ovarian surgery and pelvic complications, metabolic and enzymatic diseases, toxic autoimmune and infectious diseases. And what is the management of expected poor ovarian responders? That's pituitary suppression regimens, for example, modify the long protocols. It is more convenient for younger patients with first or third group with suboptimal response to the stimulation. Also, we can change the type or dose of gonadotropins. We can use Elonva, or we can add LH medicines, mild stimulation, IVF in natural cycle, dual stimulation or trio stim, that's 2 or 3 stimulations during one menstrual cycle to obtain more oocytes and freeze them, and egg donation. In this presentation, I would like to show you our prominent case of the patient with extremely low ovarian reserve and poor response who kept going to use her own oocytes. As an example of different strategies which we use with such patients in our clinic. The patient was a female, 33 years old, with 7 years of married life and trying to conceive since then. She was diagnosed to have ovarian endometriomas of both ovaries, and she underwent surgical treatment, laparoscopy in 2013, where cystectomies of both ovaries were done. There was also a male factor, oligostenozospermia. And we started treatment in 2014. Her antral follicle count was 5. Her AMH was 0.25, and she was 36 years old at that time. And she was in the 4th group of Poseidon criteria. She underwent mild stimulation with clomiphene citrate and highly purified human menopausal hormone. We received 4 oocytes. 2 of them were matured and performed XC, but endometrium thickness was 4.6, and we frozen 2 embryos on day 3. After that, the couple proceeded with frozen 3rd embryo transfer 1 month later, and the endometrial preparation with an estradiol and progesterone protocol resulted in a trilaminar endometrium with a thickness 8 millimeters, and the 2 preserved day 3 embryos were thawed and transferred to the patient's uterus. The recipient unfortunately had a negative pregnancy result. After that, she had 3 more attempts with mild stimulation, and all the time we retrieved not more than 2 oocytes, and only 1 oocyte was matured. We performed XC. The endometrium thickness was sufficient, 7-9 millimeters, and we performed embryo transfers on day 3 and 5, but all the tests were negative. The patients were offered a program with donor oocytes. The pregnancy rate in oocyte donation is much higher, and it's a treatment of choice for such patients with extremely low ovarian reserve and advanced maternal age. But patients, here you can see our results at 70% in the group less than 34 years, and 57% over 40 years. That's the results of our clinic. But the patients flatly refused and insisted on continuing the attempts with their own oocytes. Her general physical examination was satisfactory and with no significant past or family history. And I should mention that all of the examinations were regularly provided. So we proceeded to conventional controlled ovarian stimulation. And the 5th attempt, we had 4 follicles, and after stimulation with Elonva and highly purified HMG, we still got only 2 oocytes. Both of them were matured. We performed XC, and 2 embryos of sufficient quality were transferred on day 5. And HCG was positive. The pregnancy stopped developing during the 77th week, and vacuum aspiration was performed. Unfortunately, we didn't have karyotype that time. And how many cycles should we provide to have at least one euploid embryo. Of course, we again proposed her donor oocytes, but she decided to continue with her own eggs. Next attempts we decided to do in the natural cycle, and in the sixth attempt we got one oocyte. It was matured. We performed XC, and again HCG was positive, but again the pregnancy stopped developing during the 6th week. Vacuum aspiration was performed, and karyotype of abortion was with multiple chromosome disorders. So we proceeded to PGS, and in the 7th attempt, during the natural cycle, we got one matured oocyte, performed XC, and tried to make biopsy of 12 ectoderm, but there was not enough material for PGS, unfortunately. During the 8th attempt, in the natural cycle, we also had one oocyte and performed XC and PIXC. And PGS showed us multiple genetic disorders. In the 9th attempt, with mild stimulation, we got two oocytes and one matured oocyte, and PGS showed us monosomy of the 23rd chromosome. In the 10th attempt, also in the natural cycle, we got one blastocyst, and PGS showed us the 23rd and monosomy of the 23rd and the 17th chromosomes. So when should we stop? The patient didn't want to stop, and we continued using her own oocytes. And in the 11th attempt, we got one embryo, but there was not enough material for PGS, so we frozen that embryo. In the 12th attempt in the natural cycle, the embryo stopped on day 3. And during the 13th attempt in the natural cycle, we got sufficient blastocysts and decided to collect it and frozen. And in the 14th attempt, we used mild stimulation and only with HMG and retrieved two oocytes, but there was no fertilization. So this just proved that it's very hard to find euploid embryon in such advanced the maternal age. And the patients decided to use donor oocytes. We prepared a donor and decided to start stimulation, but before that, we decided to transfer that two blastocysts, which were frozen just for the will of God, and frozen embryo transfer of two blastocysts from the 11th and 13th attempts were performed in the natural cycle, and we obtained ongoing pregnancy, which was followed by the delivery by cesarean section, and the healthy boy was born during the 38th week. The maternal age was 42 years old. It took us 6 years. It was the 17th embryo, and 21 oocytes were retrieved. And they just proved that statement that in the advanced maternal age, we should get about 20 oocytes to have at least one euploid embryo. The choice of the optimal treatment protocol allows us to achieve the desired goal, a healthy child and a healthy woman with a successful pregnancy and childbirth. Using donor oocytes helps us to reach this goal faster, and parents can spend more time with their future children. It is a friendlier way for patients with poor ovarian reserve. And our center has a big bank of oocyte donors, of cryopreserved oocytes, of cryopreserved embryos, and good results. And our approach is highly individualized, and we use different strategies for different patients. But we provide awareness and respect the choice. 6 months or 1 year with the egg donation to reach the goal, or 6 years with own oocytes in this example. The unsupervised violence path will be overcome by the one who walks it, and we will help you to become parents. Thank you.